All right, good morning, guys. Thanks for jumping on with me. I know it's 11 for you, Charlie, and Sachin, it's noon for you, right?
Yep.
All right, you're in Jersey?
Yep.
All right, and Charles is in Illinois at the moment, getting ready to go to Virginia, right? Virginia Tech, is that where you're going?
Yes, sir.
Right on. So I had Charles with me yesterday for a session discussing medical nature of illnesses and interventions. Today we're going to spend a couple hours talking about medical mechanism of injuries and the interventions that you could perform during those types of incidents. Kevin is getting ready to join us. Kevin is from Maryland. Welcome, Kevin. So also today we've got Gretchen. She's one of our instructors, been an instructor for a lot of years. She's a super paramedic, and so she has lots of experience and stories. She does a lot of our virtual instructor-led training for our refresher sessions, and has been for a lot of years. So she's got hundreds of hours under her belt with this online training. Not so much via video, but it shouldn't be a problem. So while we're not doing skills today, I like to start off with the assessments to allow you to start thinking about what you're going to do. I think if you can do a really good assessment, then you can do a lot of the other skills we're going to cover. But you've all got these boxes full of airway equipment and splinting equipment, and we'll get to those in other sessions. Gretchen is joining us today because she's going to start doing this and start taking over some of my students. I currently have about 40 to 50 that are assigned to me, and it's getting overwhelming. So luckily it's only you three that I'm really working with right now. Everybody else is right in the middle of their course and working through things. But depending on the student, there's lots of questions, which are okay. So kind of do it in the same format as we did yesterday. Sachin, this is an interactive type of session where I'm looking for feedback from everybody. Don't worry about stepping on other people's toes. I'm going to call some of you out from time to time. Gretchen, this is the first time I've had 3 students in one classroom. And so I'm still trying to determine whether I like multiple students or whether I like to do one-on-one. It's obviously easier with one-on-one to, if I only have one, they have to answer every single thing. But this multiple students gives opportunities to ask questions so others can learn. And so we'll see how it goes. All right. Yeah, we got Ho, Lad, and Sachin. How do you say your last name?
Taduvai.
Taduvai. Okay. Easy enough. Right. So we're going to talk about trauma mechanism of injuries. So, for example, a fall is a mechanism of injury. Is it a mechanical fall from standing height? Is it a fall out of a chair? Or is it a 30-foot fall off of a roof? Depending on what exactly happened, different type of injuries can occur. So, Charles, what's another mechanism of injury?
The mechanism of injury can be a collision or or fracture.
So, yeah, and I guess maybe I'm saying it wrong. Mechanism of injuries. How did the incident occur, and what did that look like? I guess I'm also looking for types of injuries. So just like you said, fractures. What's another traumatic injury that could occur? Kevin, what you got?
Like contusions.
Okay, so contusions. Yep. Sachin, what do you got?
Blunt trauma.
So blunt trauma. Okay. Charles,
Dislocations.
dislocation? Yeah, for sure. Gretchen.
But a compound fracture.
Oh, jeez. Let's take the simpler route. Kevin.
Penetrating trauma.
Yes. All right, Sachin, talk about what type of penetrating traumas we could see.
I guess. Would a stabbing wound count?
Yeah,
A
absolutely.
stabbing-
So I'm thinking stabbing, GSW,
Ice picks.
ice picks. Yeah. I'll give you guys. I'll show you a picture of a guy I found this morning with a stick sticking out of his leg. It was a final sign off for a girl in North Carolina, and I threw this scenario at her. Oop. We're not gonna. I'll just show you the picture today, but you know, something like that. How do you manage that? Again, I'm not asking you to answer the question, but these are things that you definitely could come across. And you have to really triage the whole scene. You know, what happened? What's the patient condition? What's their chief complaint? Is it truly just a stick, you know, sticking in someone's leg, or has it severed an artery? Is it occluding an artery? So if you were to manipulate that any little bit, are they going to bleed out? You know, is there any secondary injuries or broken ribs or broken teeth? So lots to think about. You know, on a conscious and alert person with a stick sticking out of their leg, it's a pretty BLS call. You stabilize that injury and transport. They may need some pain medication and such. On any significant trauma, we always request a paramedic, but that doesn't necessarily mean the paramedic's going to do anything for them. So, all right, what other traumatic injuries could we have?
Traumatic brain injury.
Yeah, that's a good one to talk about. Kind of touched on it a little bit yesterday with the, you know, sudden onset of seizures. How about burns? Burns is a pretty nasty one. All right. So as we go through these, you know, you need to understand that these are like some of the basic things we're going to come across. Just 2 nights ago, I had a girl with a fish hook in her neck. You know, how do you mitigate that? You know, we live in an area where there's lots of logging. How do you deal with a tree that has landed on somebody's leg? You know, do you carry a chainsaw in your ambulance? Probably not. But in most areas, there's at least a fire department available to come cut that tree, or a logger on site to help you. So you use the resources available to you to handle your scenes. Okay, so falls. What's
Can
that?
I say something real quick, Adam?
Yeah, jump in.
Sorry. Okay, so when you guys do trauma assessments, like in the whole world of trauma assessments, and we just talked about like a lot of different traumatic injuries we can find, right? Well, part of it is like how you initially come into your assessment, if that makes sense. So this sounds crazy because like EMS is very, very sciencey, but when you're doing a trauma assessment, try to see it like you're the painter of a picture, okay? So your patient assessment is the picture that you're trying to figure out.
Cut out. Can everyone still hear Gretchen?
No.
You cut out, Gretchen. I see a lot of waving. I don't know what happened.
Can you hear me better now?
Yeah.
Yeah.
Okay, sorry about that. Now I'll just look like I'm flying an airplane with my hands.
Okay.
So, where did I cut out?
You said trauma was like painting a picture.
Okay, so when we showed that picture of the guy with the log, right? And you look at that patient and you say, oh my gosh, he's got a log coming out of his leg. It's really easy for you to look at the picture and think that that is the main focus, right? But you could literally miss the gorilla that's like over in the corner dancing around, okay? So whenever you do a trauma assessment on any patient you ever come across, don't go so quickly to the this is the focus, if that makes sense. Because disgusting injuries are really easy to be like, this is the focus. This is what's got them. Same thing with like Adam was just talking about burns. You see a burn, it's like, oh my gosh, there's charred flesh. It smells terrible. Your patient's screaming in pain. But your patient could have fallen off of something into a fire. And I say that because I've had a patient that fell 20 feet into a fire pit. The burn was not the biggest problem they had going on. So anytime you do a trauma assessment and you're looking for all these specific injuries, make sure you are doing a good job of looking at the whole picture and making sure that you don't have a gorilla over in the corner that's actually important to see versus the big log in the middle.
Yeah, that's a great point. On that same incident where the guy had the leg or the log in his leg, he was a passenger on a UTV, and the driver ended up with several broken ribs because another part of that log and branch hit his ribs. So while you're dispatched initially for that guy, you know, maybe initially when they called 911, the guy's like, oh, take care of that. That's nasty. And then progressively over time, he starts having difficulty breathing. You know, he is something or a patient you should be triaging as well. That's why your National Registry skill sheet reference is this my only patient. Maybe that driver is working on a pneumothorax, needs rapid transport much more than that guy with the leg sticking or the stick in his leg. So, yeah, that's a great point. What is the whole story? And I think I referenced this yesterday as well with the chest pain patient. You know, is it cardiac chest pain, or did they just get kicked by a horse, or is it related to anxiety, or do they have a stick sticking out of their chest? What is that? What type of chest pain is it? So we have, let's just say we have a mechanical fall of a 80-year-old female. She fell from a standing position. What's significant about that, or what do we need to ask or do? And I'll let you reference your skill sheet up toward the top. BSI, scene safety. This is my only patient. Considers something. What do you consider?
For age?
I would consider that, but there's something more specific on the skill sheet. You know, she's 80 versus 32, falling from a standing position. Could definitely be a difference there, but you're going to want to consider C-spine precautions. So are they having cervical spine issues or back pain? You want to consider putting a C-collar on. So I referenced it yesterday with the chest pain patients. You know, don't just assume that a 30-year-old having chest pain isn't having an MI. Same with the middle-aged male that falls down the stairs. Most of the time, a 40-year-old male that falls down the stairs is going to get up, shake it off, and move on. But we had one several years ago that tripped, fell down the stairs, and one of our other instructors, Ryan Asher, ran on this guy, fractured his femur after falling like 6 stairs. And that typically doesn't happen, but there was an underlying issue. The guy ended up having bone cancer, had no idea, and died a couple years later. But there could be something underlying that you just don't know about that causes further injury. So somebody that falls 30 feet off a roof, what's significant about that? Or what type of injuries could you expect?
You're definitely going to expect some kind of shock.
Okay. Why? Shock? What are you talking about? They fall, they land on their feet. What are you expecting?
You could see a dislocation in a bone, or you could see a fracture.
Yeah, absolutely. So you're thinking all that energy just of them landing on their feet transferred up through their bones, up through their back, and that's if they landed on the ground. What if there's a pile of rebar or fence posts or uneven ground or rocks? So absolutely, considering compound fractures, tib fib, maybe hip, femur issues. So you got to really, like Gretchen said, paint a picture of what's going on, do a really good thorough assessment. Let me run and grab another notepad. And Gretchen, if you have anything to input, go ahead.
With trauma, it can be pretty deceiving. We talk a lot about with trauma there being the specific injuries versus like multi-system trauma. And you'll find that with trauma, as you do assessments and see patients in the field, that you're going to have traumas where the mechanism of injury equates death, if that makes sense. But your person has like a dislocated toe. And then you're going to have issues where it's like, I seriously don't know what killed them. So that mechanism of injury, whenever you go into an actual call later on, or even your National Registry trauma sheets, it talks about like what's your nature of illness versus mechanism of injury. We see that a lot because why did the person, so here's an example. You roll on a motor vehicle accident, roll over. The occupants are both wearing seatbelts. The female patient appears to be totally fine. The male patient is blue and agonally breathing. What's your initial thought for this? Anybody?
So the female patient wasn't injured really at all?
Right. So we've got two people, same car. Female patient is yelling, "Help my husband." Male patient, blue, agonal breathing. So as it goes on, it turns out from questioning the patient who's fine that they were actually en route to the hospital with the husband having chest pain, right? The husband clutched his chest, said, "I can't breathe," started turning blue. Wife looked at patient, drove off the road, hit the ditch, rolled, right? So when you come into that scenario, you're like, oh, this is caused by traumatic injuries. Like, does he have tension pneumo? Does he have cardiac tamponade? Like, what's going on, right? But in all honesty, the roll had nothing to do with his condition, right? So that's why even with trauma, we still do mechanism of injury versus nature of illness, because if you treat your patient like he has a tension pneumo, but he's actually having a tombstone heart attack, which is what the case actually was, no amount of needle decompression or whatever, as you get advanced and advanced, is going to help, which is why when you take a basic EMT class, you cannot move up as an EMS unless you're a really good basic. So if you take a basic class and you're like, I want to be a paramedic someday, or I want to be an advanced someday, this, in my opinion, is the most important class you can possibly take. Because if you can do a good trauma assessment as a basic EMT with very minimal interventions, you will be a better advanced, you'll be a better paramedic.
Yep, I agree. So let's take that motor vehicle accident and kind of break it down. So we're going to look at all the different injuries that could occur, ones that we've seen. So if we have Motor vehicle accident, and they have, somebody mentioned a contusion. They hit the windshield, and one single driver, they drove into a pole, and you arrive on scene, and they've got a big goose egg on above their right eye. What do you want to do for that? Or what can you do? What would you expect your patient to be presenting like? Satchet, what do you think?
Sorry, could you repeat the situation? My bad.
So single vehicle drives into a concrete pole in a parking lot, drove off the road, drove into a parking lot, hit a pole, and their head has hit the windshield. Now they have a large contusion above their right eye. What would you expect, or what could you expect? They're driving, say, 55 miles an hour.
Do you think a possible hemorrhage could be like a concern or no?
Absolutely. It definitely could be, depending on the age and depending on what medications are on. They could have some sort of brain bleed. What else, guys?
Head trauma of some kind since they hit the windshield.
Yeah. So I would be expecting someone to be working on a concussion. You know, that contusion probably isn't bleeding. You know, they got the big goose egg, but yeah, I might put a sterile dressing on it. But I'm going to be more worried about what's going on. That brain hitting the front of that skull, maybe a little coup contre coup going on. So that traumatic brain injury that you brought up, Charles, you're going to be repeating their questions, wondering what happened. They may be even unconscious. So you're going to be worried about cervical injuries. All right, same incident. Let's throw a fractured forearm. So they have a broken radius and an ulna, and it's obvious. You see that their arm is drooped down. It's an obvious break between the wrist and the elbow. How do you want to treat that?
Use a sling.
Use a sling. Before you go to a sling, what do you want to do?
I'm gonna splint it.
Check
You want to splint it? Okay, just briefly describe to me how you're going to splint something like that.
I'm not sure if I'm being honest.
Okay. Have you had a chance to watch the Longbone video yet?
Yeah, briefly.
Okay.
My dad explained it a little briefly too, but he didn't go into too much detail.
Okay, so splinting is very easy. You're going to want to try to splint the joint below and the joint above, and try to stabilize that injury so it doesn't move. You're not putting a cast on them. You're not going to be, you're just simply putting a splint on, whether it's a cardboard splint, SAM splint, an air splint, vacuum splint. You're just reminding them that they shouldn't move it. Once you have them in whatever splinting device you have, and you guys both have, or you all have cardboard splints and SAM splints. And after today's session, I recommend that you watch those videos again and practice on yourself and whomever you can to feel what works good. So you put that splint on, you wrap that Acrylex, that gauze around it, and you stabilize it while checking your CMS before and after, and then placing them in a sling afterwards. So let's change it from a broken forearm to a broken ankle. Same type of thing, same splints, just organized in a different fashion. Checking your CMS, checking your circulation motor sensory, and trying to stabilize that area as best as you can, and then transport. Again, this isn't a cast, it isn't staying on them for very long. It's just reminding them not to move their foot, may provide that little bit of stability to where it doesn't cause further damage. So motor vehicle accident, and let's just say it's a vehicle versus pedestrian, and they have a femur fracture. What are some indications for using a traction splint for, what are the indications of using a traction splint? Sachet. What's the traction splint used for?
Open fractures?
No. Try again.
Closed fractures.
Closed fractures of what? What bone?
The femur.
The femur. So there is research out there. So we've always been taught that a traction splint should not be used on an open femur fracture. There's documentation out there and studies out there that show that maybe that's not such a bad idea. But it's dependent on and subjective to the author and the provider. Nonetheless, the traction splint. Go ahead, Gretchen.
Oh no, it's okay. You go ahead.
The traction splint. There are several different types of splints. You guys have I think it's a CTE. It's essentially a tent pole type of. It's like a Kendrick traction device, but it's supposed to be used for a mid-shaft femur fracture. It's not used for a femoral head. It's not used for a femur fracture right above the knee. It's supposed to be used for a mid-shaft femur fracture. Contraindications of using that are pelvic instability and or fractures distal to the femur. So you got to understand that when that traction device pulls against that, you have an ankle hitch and it pushes up against the upper thigh. It also pulls everything in between. So your goal is to take that femur that is fractured and is unstable and to pull traction on it until there's easy pain. You're supposed to be stabilizing that so it doesn't rub back and forth, cause further damage, cut more vessels, so on and so forth.
So one quick thing when you talk about femur fractures and using the traction splints. So we always talk about like mid-shaft femur fractures, and it sounds great and fun and all that fact. But the issue with femur fractures in general is it requires a great deal of force to actually break a femur, right? Like you usually, unless you have bone cancer or a tumor in your bone or something of that nature, having a femur fracture is a lot of force. So a lot of times there's involvement of knee, of foot, of ankle, of hip, of pelvis. If there is any doubt in your mind that the hip or the pelvis or the knee or the ankle or the lower leg is involved, that is a contraindication for a traction splint. On your national registry sheet, when you take the test for it, if there's any kind of involvement, it's an automatic fail. It can only be used for mid-shaft femur fractures. Also, there's kind of this misconception that if you break your femur, you absolutely can't walk, which is also not accurate. My own father is a great example of that. He broke his femur. Someone threw a rugby player into his knee, and he broke his femur and proceeded to drive home from Walla Walla and walk around on it for 5 days before he got an x-ray that his femur was fractured. So we always think of femur fractures as being this like, oh yeah, they got a femur fracture. But in my personal experience, I would say that 99% of femur fractures that I have gone on, and I've been on a lot because I've always worked in areas where there's a lot of outdoor recreation, snowmobiling, skiing, that sort of thing, logging, things that cause femur fractures. I'd say 99% of the time, traction splinting is not used due to the fact that there is involvement of multi-systems, or there's more question as to whether it's their femur or their hip or their pelvis.
I put my first traction splint on in 2005, and very quickly I knew it was the wrong treatment. It was a multi-system trauma, a couple of deaths. It was a van full of a family. It was hit head on the interstate with someone that had a seizure. It was bad incident. Nonetheless, the guy had a broken ankle. I was a fresh advanced EMT, and I put a traction splint on, pulled traction, and he hollered in pain. And I realized that I made a mistake. So I took it off immediately, apologized, and handed him off to the helicopter crew.
Remember,
Go ahead.
anytime you're splinting, when we talked about the arm or the leg or the ankle or foot or you name it, you splint it. If you splinting it makes your patient tell you it hurts more, then you've done the wrong thing. Regardless of what the book tells you, I literally have transported people with arm fractures that this is how they want to carry it into the hospital, like this. They don't want it splinted. They don't want it sling and swathed. They don't want anything. And as much as that goes against everything you'll ever read in your book or on your trauma sheet or any of that stuff, if your patient is in more pain from what you've done, you're doing the wrong thing.
Yeah. That kind of brings me to a point with like placing a C-collar. I feel like in TV shows and movies, like it was always a no-no. Once the C-collar was on, you don't touch it, you don't take it off. And I'm like, and now I learned what happens in the real world. If it doesn't fit right or it's causing the patient more pain, it comes off. It's okay. If you do an intervention and it's inappropriate or causes more pain, then reverse it. Don't do anything at all. Go to pillows and duct tape, whatever it takes to provide stability for whatever injury you're working on. And that goes with, like an ankle fracture. If you don't have that SAM splint or vacuum splint readily available, then throw them in a pillow and tape around it. Just stabilize it in that one spot. All right, so someone brought up blunt trauma. So blunt trauma, I'm thinking like after a domestic dispute, somebody was hit with a baseball bat or someone was hit by a car. Depending on where it's at on that body, depends on what type of injury. So, you really got to think about it from head to toe. If somebody gets hit with a baseball bat in their head, you have that contusion, possible internal bleeding, facial injuries, airway issues. Going down to the chest, you can have broken ribs, pneumothorax. Let's talk about stabilizing someone with multiple broken ribs or someone with significant enough injuries to cause a flailed chest. First off, Kevin, what is a flailed chest? What is that? What is the definition? Or what does that look like?
I think it was like when the
Do you mind if I jump?
Yeah.
Yeah, help them out.
Flail chest is like when the was like a segment of like your rib cage is breaking due to trauma and it's starting to become detached from the rest of the chest wall, right?
Okay. Sachin, you have any idea? He froze up. So, the book definition escapes me, but it's, 3 ribs broken in 4 or more places, something like that. Essentially, it is a section of the ribs that has incurred significant trauma, and it's. Go ahead. What is it? What is the definition?
2 or more ribs broken in 2 or more places. So basically, think of it as being ribs break. These 2 ribs are broken. Here, it's its own little section of rib. So it does its own thing.
Okay. Good. And that section may be intact. It's most likely that person's going to be guarding that location. Oftentimes, it's associated with paradoxical motion. So as they breathe in, one side goes up, the other goes down, and vice versa when they exhale. That's a pretty significant. They're having a bad day then.
I got flail chest from a jet skiing accident when I was in college. And I never went to the hospital or anything, so when it healed, I still have paradoxical movement when I breathe.
Really?
It looks very weird, yes.
Wow.
But yeah, and it hurts like absolute the worst pain you've ever had in your life if you've never had a flail chest. Yeah, don't get run over by a jet ski in the lake.
Yeah. So the treatment for this is to stabilize that injury with large bulky dressing, pillow, whatever it may be. oftentimes that person's going to be holding their hand over that location to prevent it from moving around any more than it needs to. How old were you when that happened?
18.
Ooh, wow.
It happened in Coeur d'Alene, actually. But the other thing is you'll run into like old school EMS providers who still are in the world of like, oh, you need a small sandbag for Flail Chest, because that used to be the treatment. When I became an EMT, we put sandbags on everyone that had Flail Chest. But it turns out that with some scientific research, they found that if you put a sandbag on someone who's having a hard time breathing, it actually messes with their tidal volume. Who would have known? So if you are in a scenario where you're working with EMTs who have been EMTs since the 1960s, and they say, quick, put a sandbag on it, that is not the correct treatment anymore. I only say that because people do still run into these people who put sandbags on Flail Chest.
Yeah, I don't know anybody carrying sandbags anymore. So another thing with these broken ribs and flailed segments is the rare possibility of puncturing a lung and causing that tension pneumothorax. So Kevin, what's a pneumothorax?
It's when there's air that escapes into the chest wall cavity.
Yeah.
It decompresses. Yeah.
So for whatever reason, there is air leaking, whether it's a puncture from a bullet, a rib, maybe it's someone that coughs too hard and there's a little bit of air leakage, but essentially you have your thoracic cavity, you have your lungs in there, air is escaping. As they breathe, more air goes in there, so it compresses that lung, causing that tension. Pneumo meaning air, thorax meaning the thoracic cavity. So as an EMT, what can you do about that pneumothorax?
We can't actually treat it.
How are you going to treat it?
Can we do needle decompression, or is it only advanced EMTs and paramedics that can do that?
It's typically reserved for the paramedic skill. And again, depending on your protocols in your county, I really highly doubt that they're allowing any EMTs in the country to do a needle decompression. But through different military trainings and tactical casualty combat care, they may be training you on how to do it. Whether it's in your protocols or not is a whole different thing. So yeah, needle decompression, if it gets bad enough and it's a hemopneumothorax, there's blood in the thoracic cavity as well, they're going to be putting a chest tube in there to allow drainage of the air and fluid. But yeah, as an EMT, you're going to be doing a good assessment. So you're going to be checking lung sounds. You get there, you initially take lung sounds, they're good. And 15 minutes later, you have diminished lung sounds in the lower lobes of the right lung, right side. Through trending and taking good vital signs that something is awry, and that's something that's going to be part of your care report to the medic or the receiving facility. So, as far as I know, there's nothing else you can do.
Oxygen, keep them comfortable, keep them calm. Remember that with any patient, keeping a patient calm is actually like a huge part of patient care. You talk about that when you talk shock. Like if you have an anxious patient, shock goes worse. If you have a patient with and basically anything, being anxious is going to make it worse. So your demeanor and how you treat the patient and how you're very calm and composed and put together, that actually can do more than a lot of treatments sometimes. So just because it's like, oh, technically, we're just the basic, we can put oxygen on them and get them to someone that has higher level of training, doesn't mean that you can't do a really, really good job of keeping them calm, doing good assessments, that sort of thing.
Yeah, it's not even just the patient, it's the family too. They had some family members freak out about a small little cut on a forearm, and just educating them that, hey, they're conscious, they're breathing, they're talking to me, they're not bleeding profusely. I'm not doing anything for them during the transport to the hospital. They're going to be okay. Short little education, being calm, just like Gretchen said, it goes a long ways. All right. Dislocations. So, you know, it can be multiple types of dislocations. What are some things that can become dislocated?
Your shoulder.
Shoulder. Okay. Kevin.
I'll
give you a clue.
like a finger.
Anywhere there's a joint, there could be a dislocation depending on the blunt force trauma that occurs. I've been on simple dislocations of a 14-year-old girl that rolled over in bed wrong. It dislocated her arm. We get there, and the whole time I'm totally minimizing this thing. Like, what 14-year-old girl dislocates her arm at 10 o'clock at night unless she's having some pillow fight or something? I don't know. And we get there, and she legit was sleeping, rolled over, and dislocated. And we had to make a splint out of a cardboard that they had out in the garage. It wouldn't move. It was too excruciating. I had just 10 days ago a dislocated patella where the kneecap was on the lateral side of the right leg. As she got in the car, it just slipped off to the side. She had previous knee injuries. She was 18 years old. And it was fairly painful for her. It was very uncomfortable. At the EMT, at the basic level, we're lifting, moving, trying to splint that thing in place. As we got her out of the car and sat her on the gurney, that thing popped right back in place. She cried. She said it hurt really bad, and then it stopped hurting, and she refused. So we encouraged her to be seen at, a doctor, but she didn't necessarily need to go by ambulance. So more of what the National Registry skill sheet focuses on is the joint injury, shoulder dislocation, and the sling and swath of that. So a lot of your dislocations the patients are going to be holding their arm in a position of comfort. They're not going to want to move a whole lot. So checking your CMS, you may palpate the shoulder a little bit, feel for instability and crepitus, but if someone tells me that they feel like their arm's dislocated and it hurts, I'm probably not going to palpate it a whole lot because it doesn't get you anything. You can inspect it. Maybe you can cut their shirt and make sure that there's nothing sticking out. But again, it's not going to change your treatment of sling and swath or splinting that in place. So a couple of triangle bandages. You guys can watch the video on that and see how that works out. So joint immobilization using sling and swath. Shoulder dislocations don't necessarily always end up in transports, and I think we kind of talked a lot about transports and refusing patients. We have a lot of motocross in the area, and a lot of these guys are 18 to 28 years old. They don't have insurance. They're tough. They make their living on the circuit. And when they have a dislocated shoulder, they don't want you to touch them. They may allow you to put a sling and swath on them, but that doesn't necessarily mean you have to transport. I've put vacuum splints on very obvious, painful, broken legs, and they absolutely did not want to be transported. It was a courtesy. I think it was ethical that we asked them, hey, can we at least splint this? I know you don't want to go with this, and that's fine. You're going to the hospital, right? Yeah, we're going to the hospital. And they go in their own personal vehicle, but we try to provide some sort of splinting for them. What else? So dislocation, anything on dislocation, Gretchen?
If everyone remembers what's in the EMT basic book, but in little kids, especially between the ages of about 1 and 5, it's really common to dislocate the elbow. It's called nursemaid's elbow, and it's usually caused by a sibling yanking them around by an arm. I've had 2 kids with it. Generally speaking, it pops back in about the time that the parent's trying to, muscle them in their car seat and then pop, back it goes. But every so often you will see that in the field where a freaked out parent calls. I've seen a lot of calls that you probably wouldn't see like in a urban area because where I worked was a really long ways away from the hospital, and we had a lot of parents that were too drunk to drive kids to the hospital, so they would call the ambulance. Obviously, that's not the case everywhere, but when you're 2 hours from the hospital, that's what happens a lot. So generally speaking, you're not going to see it unless there's some other injury involved, but some parents really freak out about nursemaid's elbow and will call 911. So I'm sure you've had a patient or two, Adam, with that.
Probably. I don't know. That doesn't sound familiar, but I probably didn't recognize it. So,
yeah.
Do you want to go over anything else with compound fractures?
They suck. Don't get one. No, I think that with compound fractures, basically, sorry, hang on one second. So basically with compound fractures, it's a twofer, right? Like you have an open wound and you have a fracture. So take care of both. We, generally speaking, aren't going to do a whole lot other than put gauze over it and then splint it in the position of comfort. One thing that you can see that I think is a little more common with compound fractures is nerve involvement. So when you're doing your CMS, if your patient cannot feel their extremity, that is bad. Even if it's not from a neck injury, I would say that probably 75% of my compound fractures I've been on involve some type of blood flow issue or neurological issue associated with it. Also remember that when you have a limb that doesn't have good neurological and good blood flow, that upgrades it to being more life-threatening than if it was if they had CMS times 4 in that limb, if that makes sense.
So then that contraindicates like using a splint?
It would contraindicate using a traction split for 100% positive. If you have a femur fracture, even if it's mid-shaft closed femur fracture, if you have an ankle compound fracture on that side, you absolutely cannot use a traction split.
Okay.
You could still splint it. Splinting is, generally speaking, okay, but remember that you also don't elevate compound fractures. Does that make sense? So you can elevate fractures. It sometimes helps with the swelling and the pain. You cannot elevate compound fractures.
All right, let's move on to we've been going about it. We've been going at it about an hour. Does anybody need a break, or can we power through?
I'll take a quick one, just like 2 minutes.
Okay, let's do that. I'll fill up on my coffee. And Gretchen, do you want to go over penetrating trauma between stabbing, gunshot wounds, ice picks?
Yeah, I sure can. And then I'm actually going to have to log off. My neighbor has a doctor's appointment in half an hour. Sorry.
No, it's just
many kids, people.
Exactly kind of what I wanted you to witness and see how all this works. So
yeah,
and then
I can do the penetrating and then I'll log off after that. So.
I found out yesterday or this morning that Ryan does all his skills first and then focuses on his
back.
Everybody's back.
Okay, perfect. Okay, so penetrating trauma. So we talked about all the things that could cause penetrating trauma. But what are you looking for when you come across a patient you don't exactly, okay, let's give you you're dispatched for a patient with a gunshot wound. Okay, that's all the information you get. You arrive on scene, scene is safe, you're allowed to go in, you've got your gloves on, and all that fun stuff. What are you looking for in your assessment of this patient?
You're looking for where the entry wound is, and you're looking to see if there's if there's an exit wound, or if the round is still in the or if it did not exit.
Okay. What else are you looking for?
If there's like how severe the bleeding is.
Perfect.
if they're in shock. Yeah.
Yeah, exactly. Okay, so when we deal with patients who have penetrating trauma, remember that blood loss can be internal and external, okay? I really am not a big fan of gunshot wounds. Obviously, we see them quite a bit. But gunshot wounds are tricky, right? Obviously, there's more than one type of penetrating trauma. If you have a patient who's been knifed and the knife is still sticking out of them, or say they got shot with a nail gun, whether it be on accident or on purpose, or an ice pick, if it's still in them and that's the only wound, you got a pretty good idea of where you're looking for injuries, right? Gunshot wounds are super tricky. So you can have entry and exit wounds that are incredibly small, depending on the caliber of the bullet, right? So 22s, for instance, are known for this. It's tiny little hole in, tiny little hole out if it comes out. Then you've got rounds where, say someone uses a 45 with hollow points, right? So it's going to go in and it's going to blow out a chunk this big. So a lot of it's going to depend on what is actually causing the penetrating trauma, okay? So two things that you look for automatically anytime you have penetrating trauma are external bleeding and signs of your patient going into shock. Because just because you can't see the blood loss doesn't mean that they're not just pouring buckets of blood out into their abdominal cavity. Does that make sense to everybody? Yeah, okay. So the other thing is you count, if you have a gunshot wound, you count holes. That's actually really important because sometimes your holes don't add up, right? So if the patient knows they were shot twice and you find 4 holes, so that's an in and an out and an in and out, right? Okay, good, we're great. You still don't know what the trajectory has actually hit. When I was in paramedic school, we actually did something that's super cool, and you can look it up on YouTube and watch a video of it, and I would highly suggest that. It's when they shoot different things into ballistics gel. And what you see is picture now that someone's insides versus ballistics gel, okay? So some of them, if you look up the EMS specific ones, they'll have like what happens when you stab a knife into ballistics gel, right? They'll have what happens when you stab a screwdriver into ballistics gel, or when you shoot ballistics gel with an arrow, or with a 45, or with a 22, or with a shotgun, okay? So if you can visualize that, that's going to help your assessment of your patient, because you kind of, generally speaking, know what you're looking for, right? But also remember that once you get a bullet in your patient, it's kind of like that is it pinball where you pull it back and then it shoots all over? Well, that's kind of what happens when a patient is shot, right? Very rarely is it completely a through and through. The exception is like an extremity. You get shot in the arm, it's probably just going to go through. Versus if you get shot in the core part of your body, it's going to ricochet around and damage a lot of things. So if you have one tiny hole, say, in your abdomen, and there's no exit hole, and there's barely any blood loss, it's really easy to go down the rabbit trail of, what am I assessing my patient for? You have a tiny little hole with very little blood loss, right? So how would you go about assessing your patient past the initial, you have a hole with a little bit of blood? Anybody? What else are you looking for?
So you're saying someone that has a bullet hole, a tiny bit of blood, what else you're looking for? Yeah. Okay,
you're looking for signs that they're going into shock, because even if there's that little bit of blood, you don't know if there's internal bleeding, so you need to be making sure that they're not showing signs of going into shock.
Okay, so what specifically are you looking for with that?
So, like altered LOC.
Okay. What are you looking for as far as skin signs go with looking for shock?
Very clammy and cool skin.
Okay. Altered level of consciousness, cool clammy skin. What is a sign that someone has internal bleeding? There's several different ones. Can anyone throw one out? Have you guys talked about that at all yet?
You might have a rigid abdomen.
Yes. So generally speaking, when you have internal bleeding, there's pain and swelling associated with that.
Yeah, we haven't actually lectured about it.
Oh, sorry.
No, that's okay. It's just whatever they've read in the book, and
They're like, no, we have no idea what you're talking about. Sorry, guys.
I should have some idea. This is all in the textbook, so.
So if you look at your National Registry trauma sheet, if you guys have looked at that much, when we check our ABCs on that list, under C is circulation. We also look for blood loss, right? So when you're doing that, when they talk about blood loss, you're not looking for the little trickle coming out of someone's mouth, right? You see that, you note that, you're like, man, moving on, right? You're looking for the bleeding that needs to be controlled in order for this patient to survive. Does that make sense?
That makes sense.
Yeah. So especially with penetrating trauma, you can have massive bleeds associated with penetrating trauma. I think the biggest thing people fall into is the trap of, oh, it's going to have massive bleeding. But sometimes that massive bleeding is not seen on the outside. Does that make sense?
That makes sense.
It also depends on what is causing the penetrating trauma. So for instance, if you have an ice pick that's this long, right, the damage done with that is considerably deeper than if you're stabbed with a Leatherman knife. Adam, anything else you want to add?
No, just talking about the mechanism of that bullet, caliber size, how to deal with, if they're shot in the upper right chest versus the upper left chest, looking at the vascular that's going on behind there, and talking about the pneumo. Did you guys talk about the occlusive dressings or chest seals?
Oh, no, we'll talk about that really quick. Sorry. Okay, so one tool we do have as EMT basics is the ability to do an occlusive dressing, right? So how you do that, it depends. Some agencies carry like Astroman chest seals. Some agencies are like, here's your petroleum packet that you can tape to someone's chest. So if anyone's ever known that the petroleum packet is actually because you want the foil to it, not because you want the petroleum, that kind of sometimes throws newbies off. They're like, well, why do I need petroleum? You don't. You need the foil. But when you have a wound, you're going to tape it. If you start to think that air needs to be released, then you untape one of the sides. Does that make sense?
Makes sense.
Everyone? Okay. So the Astroman chest seals are my preferred use. Adam, is that what you guys use?
We have, within our rescue task force gear, we have chest seals. I don't know if they're that particular brand, but they're
okay.
Occlusive seal that allows some venting should there be a excessive pressure.
That's why I really like them, because the venting's built into them, versus if you tape on all four sides and then you have to just sometimes with your patients that actually need the occlusive dressing, they're very serious patients, and so it depends on how many of you have in the back of your ambulance, but sometimes it's hard if you're just consistently working on your patient all the way to the hospital. You can obviously see the signs that you need to release a side, but it's just sometimes harder, whereas the chest seals do that for you, so it's not as big of a deal.
Yeah. And that kind of takes the penetrating trauma. Let's hit up burns, and then Gretchen can get out of here, and then we'll jump into bleeding control and shock, that skill. So burns. Let's talk about burns. Kevin, what do you know about them?
So you can have moderate or minor, moderate, and critical burns.
Okay.
That just depends if it's like how much of the what percent of the body is like partial thickness or full or superficial.
Okay. So yeah, Gretchen and I first learned about burns as being referenced as first, second, third degree burns. That changed to partial thickness, full thickness burns, fourth degree as well. Said Gretchen. And
Yeah.
so I think this book does reference minor and moderate burns, but essentially I look at the burns as being the most simple burn is your sunburn, where it's red, it's kind of painful, it's kind of hot, and really there's no treatment for it. Most everybody gets some sort of sunburn every year, and it depends on how severe it is and how you treat that. When I think of burns that needs EMS involvement, there's blistering, it's hot oil, it's the fall into the campfire, and there are different philosophies and theories on how to treat those. So what do you guys, what'd you read about? What'd you learn about burns as a whole in the book?
My dad went into pretty big detail with me because that's what he dealt with the most, and he said that especially when you start getting into the critical burns or the third degree burns, because he still uses that term, you're going to start seeing a lot of he said it's going to seem paradoxical, but sometimes patients with those kind of burns don't feel pain because that's usually because their nerves have been damaged or basically fried. So he said that's when you start worrying, is when they say I can't feel any pain, that's when you start worrying.
Yeah, that's bad. So burns, it's if someone has a burn the size of a pop can on their arm, that's it may be significant in its own way, but initially that may not be that bad. You're going to put a nice sterile dressing on it, cover it up, and transport. Now, would the book talk about dry versus wet dressings? Someone with substantial amounts of burns on their arms and legs and chest, you want to put a nice sterile dressing on there and then cool it with sterile water. And I don't, you guys aren't 10-year practicing clinicians. I don't expect a great answer from you guys, but what does the skin do for your body?
It protects from outside pathogens.
Okay.
Allows for regulation of heat. Yes,
absolutely. So if you have someone with a substantial amount of burns, hypothermia is a substantial concern. And so, putting wet dressings on them is not going to be the best for them. On the contrary, that pop can size burn that's on someone's arm, that's maybe a partial thickness where cooling of that affected area makes the patient feel better, I might consider that. Most likely, it's still just going to be a dry burn or a dry sterile dressing, but we don't advocate. There's a bee. We don't advocate initially putting wet dressings on burn patients. What's your experience?
So I was gonna say, so my experience is, again, the last place that I've worked has been very long transport times and very long response times. So one of the things that we've seen a lot of is that most people are told by dispatch to stop the burning, right? That's what dispatch tells them when they call 911. So that involves cold water, right? Because that's just what they do. So if you have a pop can sized burn on your arm and they've put cold water on it and they're holding they unfortunately use cold terry cloth towels, which is just like, ugh, don't use that. But that's what they use. So you show up and you've already had it wet and cold for quite a while. Probably not such a big deal with just the arm. Unfortunately, what I've run into is full legs being burned from the drunken fall into the fire pit. And then they take the entire leg and put it in the lake, or they wrap it up with wet clothes or whatever. So by the time I show up, my patient is already quickly headed towards hypothermia. So you don't want hypothermic patients, especially not with burns. So we dry dressing everything. You do have to stop the burning. So if you have a burn that is currently hot and you wrap it with dry sterile dressing, you've basically created like a burrito, right? It's going to keep cooking. That's bad. You don't want to keep cooking a burn. So you do have to stop the burning process before you can do the dry sterile dressing. So do keep that in mind. I would say that we can go down the path so far of like dry dressings, don't use wet, that we forget that you first have to stop the burning. Again, it depends on your response time. At Priest Lake, where I last worked, we didn't get anywhere quickly. So usually the burning process was well done by the time we showed up.
Yeah. That's a good call. And you know, depending on whether it's a burn from a fire or say a chemical burn, you know, if there's a chemical burn with those chemicals that are embedded within the skin, and the only way to stop the burning is continuous irrigation of that affected area, then that's what you do, is continuous irrigation. But don't forget about medical control too. You know, if you, as I said yesterday, you come across a pretty critical incident in your first month of being an EMT and you don't know what to do, first off, you better have that ALS or next level of care en route. But also don't forget you have, if you have cell service or radio service, you can contact medical control and get some further advice from them. So there are some burn sheets and burn blankets that essentially just provide that sterile environment to try to prevent further materials from getting in there. But yeah, the leg in the lake, the dirty towels and shirts around the burn, you've already you're behind the game on that situation. But
what are some types of burns that are considered to be much more serious than other types? And I'm not talking like first or second or third or partial or full or anything like that. I'm talking like specific areas that can be burned.
Like the eyes, or you mean like specific parts of the body? Mm-hmm. Okay. Like the face, or I think the feet.
Mm-hmm.
The lungs can be burned, right? Especially if they
Yeah, so that would be more of an inhalation burn, which you're obviously not going to see that the lungs are burned, but what are some signs that you look for in that patient that possibly has an inhalation burn? What's your outward signs that you can look for that?
I'm not sure exactly, but I believe it's more of the sign of like they're not breathing normally, or they're like struggling to breathe.
Yeah, so soot around the mouth, nose, singed nose hairs, that sort of thing, burned tongue, swollen tongue. Anytime you have an airway burn, that's something that you need to call for ALS as quickly as possible. A lot of times what happens is that when someone gets burned, they swell, right? That's what happens. And if the upper airway gets burned, it will swell shut. And pretty much the only way you can get an airway is surgically, if you missed a boat on that. So you want to call for ALS as soon as possible so that you can tube your patient before the airway swells shut. Even paramedics are going to have a hard time. Once you switch to surgical airways, the chance of survival is very minimal in the field, unfortunately.
Yeah. Yeah, and we had a helicopter go down about 5 miles from where we're at right now about a month ago, and the two survivors from that crash, it went down, they walked away from it, they're on scene answering questions, and they did have soot around their mouths, and providers looked in their airways and determined they inhaled some superheated gases, and both of them were transported and intubated while en route. So they can look fine too. They had no other traumatic injuries. They just inhaled some heat, and one ended up passing a couple weeks later. So learn from that.
So genitals are another thing anytime you have genitals involved in the burns. So you guys probably, everyone knows about the infamous McDonald's burns lawsuit with the hot coffee, right? Yeah, so everyone's like, oh my gosh, you sued because you got burned with hot coffee. Well, interestingly enough, what actually happened is that the coffee was almost boiling, and the coffee did not say hot or anything on it, and the lady dropped the cup of coffee on her crotch. And she ended up being in the hospital for, I think it was like 90 days in a burn center. Wow. So when we think of like the McDonald's burn, it was actually that she wanted her hospital bills covered because they were so expensive from McDonald's serving boiling coffee. But the moral of that story is that if you have boiling liquid that's dropped on a crotch, or boiling liquid that's dropped on someone's face, these are injuries that are much more significant than if you drop boiling water mid-thigh, right? It might be ugly, it might hurt like hell, but you aren't going to have the infection rate or the other things damage you can with your face or your genital area. The other thing we're always looking for with patients is circumferential burns, especially with the chest. If you have circumferential burns across your chest and you're trying to take a deep breath as that swelling happens, it almost works like a constricting band. So you swell on the top, you swell on the bottom, but this part doesn't increase, so you can't take deep breaths, which then causes you to have significant breathing problems, right? Same thing with circumferential burns around a limb. If that's constricting, you're not going to get the blood flow you need. Also, it can cause your nerves to not work like they're supposed to, and it can actually lead to compartment syndrome. So we definitely want to look for circumferential burns. On the sheet of things that you need to let the hospital know about as soon as possible, genitals, facial involvement, upper airway involvement, and circumferential burns are on that list. It's also on the list that makes a burn flyable versus not, if you're in an area where you're calling a helicopter. The other thing with burns is that they're nasty, and a lot of times we get distracted by them. So if your patient had something else happen and then got burned, it's important that we do more investigation than just stopping at the burn, if that makes sense. We don't just see a burn and say, yep, that's it. All right, check that box. This is their problem. You got to do more questioning and figure out if they actually got burned and that's why they got called, or if they passed out into a fire, or if they were involved in a traumatic injury and then got burned as part of that. That makes sense to everybody?
Makes sense.
So let's finish this topic up. I just want to remind you guys to look at the rule of nines illustration in your book and think about it. I had a student question me not too long ago about the percentage of burns on a body, and it referenced the anterior portion of the arms and maybe their chest. And so, for example, like your whole arm is 9%, another arm's 9%. So if it's only the anterior portion of your arm, it's 4.5%, and then the whole chest area is 18. But if it only references, say, the abdomen or the chest only, then that's 9. But there tends to be some burn questions within your final exam and possibly the National Registry as well. So with that, let's jump into the bleeding control and shock skill sheet. And Gretchen, by all means, you can stay or go.
I'm gonna go. Everyone's screaming upstairs. Nice to meet you guys.
Thank you.
So bleeding control and shock. Let's just give you a little bit of history with the bleeding control skill sheet and where we as a society and EMS have changed. In the years past, when I first took my EMT class, it was, and Charlie, when your dad too, using a tourniquet was like an absolute no-no. You just don't do it. Thought process was that it causes more cell death, and you know, if you put a tourniquet on an arm, you just cause that person's arm to be amputated. Well, with all the wars and military things that are going on, we recognize that the tourniquet is saving lives, and it's not causing as much cell death as once was thought. So roughly, I don't know, maybe 9 years ago, the National Registry changed their philosophy and changed their skill sheet to where if we have someone with uncontrolled bleeding, that we first try to stop the bleeding with direct pressure and some sort of gauze or sterile dressing. And if that doesn't work, we go right to a tourniquet. And so the old skill sheet was direct pressure, then it was elevation, then it was trying to find a pressure point or a way to stop that bleeding. But we just go right to the tourniquet. And the tourniquet, something else that's kind of happened in the last 5-6 years is something called Rescue Task Force. So you guys were pretty young when this happened, but in 1999, April 20th, 1999, I believe, or 98, the Columbine shooting in Colorado happened at the high school. So several students, teachers, and such were shot, and they essentially bled out because providers wouldn't go in there. A scene wasn't safe. The active shooters were unknown. And there's been so much research and so much, such a paradigm shift within the medical community and what we do in those situations. Right now, we, fire and EMS are going into certain zones that before we wouldn't go in. So you probably learned this in your ICS class, but there's hot, warm, and cold zones. And a hot zone, like on a fire, is a structure fire inside the fire. A warm zone may be on the front porch where it's safe, but you still need your breathing apparatus. And the cold zone is out on the street where the civilians are. There's no chance of danger. And so now within the medical community in EMS, we are going into warm zones. So say there's an active shooter, whether it's at a house, a school, a place of business, wherever it may be, and somebody is actively shooting, law enforcement will go, they will make contact with that person. They will either neutralize that person or what they call push them off the X. They'll push them off that initial place where the people are injured, and they'll push them to a back room, and they'll keep pushing them away. And where that shooter is and law enforcement is, that's the hot zone. If it's depending on the type of building, and this is a full week-long class or a longer class than just the 15 minutes I'm going to describe it. But we have ballistic vests that have a lot of chest seals, bleeding control, tourniquets, and types of things that where we form what's called a rescue task force. So once law enforcement has that person moved off and they establish a warm zone, that means that it's safe for us to go in and mitigate patient care or mitigate the patient. So we do a quick triage. We drag that person to a casualty collection point or a triage area. We don't come across people, determine that they need CPR and start CPR. We determine whether they're alive or dead, breathing. We might open an airway. We might come across someone with uncontrolled bleeding, so we'll place a tourniquet. But we don't necessarily do patient care from start to finish. We go in, determine the number of patients, take them to a collection area, and arrange for transport with the incident commander or whoever it may be. So using a tourniquet, it really goes along with this bleeding control and shock skill sheet. So if we have someone that has, it doesn't have to be a gunshot wound. It doesn't have to be, a crime that was committed. It can be an accidental shooting. It can be an accidental stab wound. It could be a hunter that is skinning an animal and accidentally cuts themselves. It could be an amputation after a motor vehicle accident. But we have to recognize that if it's substantially bleeding and direct pressure won't immediately stop that bleeding, we have to revert right back to the tourniquet. So if it's anywhere on the arm, you have the radius and the ulna on the forearm, you have the humerus up here. Anywhere on that arm, we advocate that you place a tourniquet high and tight. So you have one large vessel coming down the humerus, which is what vessel? What artery is this right here?
Brachial artery.
Yep. So if you break your artery, so you have a higher chance of tamponading or occluding that artery to prevent further blood flow. And how tight would you make a tourniquet on someone's arm?
They had us do a bleeding control lesson in core. They said make it tight, but not to the point of where it's like crushing arm, but tight enough that it's going to control the bleeding.
Exactly. So you're going to want to make it tight enough to where it stops the bleeding. So essentially you're stopping that bleeding wherever the systolic blood pressure is. And, you know, it might be painful for the patient, but, you know, tell them what you're doing, describe what's going on, and that's what you have to do. So if I have a leg injury, where would you place that tourniquet?
Also on like the upper thigh.
On the upper thigh?
Yeah.
Yep, exactly. So the same type of theory, high and tight, and tight enough to where it stops the bleeding. So there are several tourniquets out on the market. We sent you what's called a CAT tourniquet, combat application tourniquet. And one of the reasons we're using that is because a lot of the soldiers and contractors that we have coming through our classes recommend that. They say that is what works the best for them. And so there's multiple manufacturers out there, but that's what we use. What's another thing that you have in your toolbox that you can use to use as a tourniquet?
The roller gauze?
Nope. Your blood pressure cuff. So you place that on the arm, pump it up, and you know, pump it up enough to where the blood stops flowing, and leave it in place. The other thing you're going to want to do is document the time, whether you write it on the patient's arm, write it on the tourniquet itself, or pass on that information to the receiving facility. So if you haven't already, go ahead and pull those tourniquets out. And if the plastic is still on it, go ahead and remove the plastic. Yep. Go ahead
I
and
have a couple.
Go ahead and remove the plastic, Kevin. You had a question there, Charles?
Oh no, I was saying that I have a couple in my dorm before I had to move out. They're all sitting in a storage locker right now in Virginia, so I got to go get them.
Gotcha. So law enforcement is also carrying tourniquets. A lot of times they're carrying them on their belt along with their handcuffs and their gun. So that's a good thing. So if you pull those out of the package, you kind of see that there's a Velcro. It's already affixed in a circle. And so if you have someone with a fairly large thigh, you can undo that Velcro and take that strap all the way out and then wrap it through there and tighten it up. We store these essentially as they're shipped, except we take the plastic off so we can access them faster. So go ahead and place that tourniquet above, or place it on one of your arms. So place it high and tight, and then tighten it down with the Velcro until it's snug. So one of the things that we do is advocate that you put this on yourself, because you might have to administer your own tourniquet in the field depending on what happens. So Kevin, how far above that elbow is it?
About like 2 or 3 inches.
Yeah, you can even go higher.
Okay.
So, on the upper, just distal from the shoulder above the bicep. So anywhere in that area, yeah, exactly. So you're gonna want to tighten it down just a couple, so you can kind of feel what that might feel like. I don't want you to cut your circulation off or anything like that, but I want you to get a feel what that's like. What that does, it's called a windlass. You twist that. There's a strap inside that tourniquet itself, and it tightens down around the arm and the vessel. And then you can see that you just lower it down into that part where it has the white Velcro strap that says time. It holds it in place. There you go. That's good. Kind of see how that works? You put that white strap over, so lock it down in there. There you go. Perfect. And that's where you can write your time. And so essentially you leave it in place. You don't need to remove it. I know we talked about interventions earlier. If it's hurting the patient, that we can remove whatever intervention we do. However, this is one that if they're profusely bleeding, if it's bright red blood, we're kind of life over limb. We need to stop that bleeding, and it might hurt for sure. So what are the differences in blood vessels? So what's blood from an artery going to look like versus blood from a vein? Charlie, talk about the artery.
So the artery is like the muscle tube wall of the circulation system, and it's the blood that's carried in that part is actually oxygenated compared to the blood going through the veins. Okay.
Is it going to be oozing, or is it going to come out under pressure, or what's the blood from an artery going to look like?
I'm sorry, I don't know.
It's okay. Kevin, you want to help him out?
It's going to be like bright red and like spurting.
Yep. Versus a venous bleed. What's that going to look like?
It's going to be darker and often slower.
Yep.
It's not as much pressure.
Yeah, it's going to be oozing. Going to be a little bit darker red. Exactly. And, if it's uncontrolled bleeding, it's not going to matter whether you put a tourniquet or not. You need to control that bleeding. You just need to document what you saw before you determine you need to put a tourniquet on. I've seen law enforcement place tourniquets on gunshot wounds that maybe don't necessarily need tourniquets, but you got to understand they are taught to place a tourniquet on any significant trauma where there could be uncontrolled bleeding. So, it's something that I would consider just putting direct pressure on and waiting for that thing to stop bleeding. They've been taught to put a tourniquet on right away. So practice this skill between here and some other time we meet before I test you. You guys should be at a point where you don't necessarily need to reference notes to answer some of these questions. I would just encourage to do some more studying so you don't have to look up every single question I ask, and review some of those test questions that you've taken before. What else? Bleeding controlled shock. So practice it on other people. Had something else I wanted to talk about. I think that's it. I will bring it up with you guys later if I think of something else associated with it. Oh, I know what I was going to bring up. So what if you have that uncontrolled bleeding from, say, an abdomen or a neck? Is that, say if you have your jugular vein is profusely bleeding, what are you going to do for that?
Don't put a tourniquet on that.
No, you can't put a tourniquet around your neck. So direct pressure, significant direct pressure. What if you have uncontrolled bleeding from your abdomen? You put a tourniquet anywhere for that?
No.
No, typically not. Typically it's going to be direct pressure. If someone's having significant bleeding from their abdomen, most likely it's going to hurt significantly, and the person's going to be guarding that and not wanting you to touch it. But you might be able to do some direct pressure, but most likely it's going to be a rapid transport for sure.